Good morning, students. Good morning. Today we are having Immunology lecture number 5-6. I have said at practical classes that this lecture is combined. This lecture is combined because there are just some questions, about 5 questions in lecture number 5 and 5 questions in lecture number 6. So I always combine them because we will have time for reworking in the end of this semester, and we will finish immunology earlier. Firstly, I want to remind you what did we discuss it in immunology. We talked about organs and cells of immune system in lecture number 1, or we talked about non-specific defense like phagocytosis, lysozyme or complement in lecture number 2. Then in lecture number 3 we discussed antigens and antibodies. It is specific immune defense. This week we have talked about hypersensitivity. Hypersensitivity, it is hyperreaction. It is abnormal immune response to antigens, to some antigens. So we can say that hypersensitivity is one of the pathology of immune system. And today's lecture is about immunodeficiencies. Today we are going to talk about pathologies of the immune system. In other words, we will talk about immunodeficiencies or deficiency of immune system. Firstly, we will discuss these questions. What are immunodeficiency? What are their classification? And then in another part of our lecture, it's in lecture number 6 here, I will tell you about evaluation of the immune status, how to evaluate, how to measure, how to detect immunodeficiency. Let's start. The first question, sure, it is definition. We should understand what is immunodeficiency, definition of immunodeficiency, and classification of immunodeficiencies. What is immunodeficiency? Immunodeficiency is a disturbance of normal immune status caused by defect of one or several mechanisms of immune response. Once more, immunodeficiency is a disturbance or disorder of normal immune status that is caused by defect of mechanism of immune response. Which mechanisms of immune response? You remember. It includes defects in all components of immune system, including B cells, T cells, and natural killer cells, phagocytic cells, and complement proteins. So immunodeficiency may be caused in any mechanism of immune response, like B cells deficiency, T cells deficiency, phagocytosis deficiency, or complement deficiency. Immunodeficiencies may be classified into 2 big groups. The first group, or the first type of immunodeficiency, are called congenital or primary immunodeficiencies. They result from abnormalities in the development of immune mechanisms. They occur because of genetic defect, because of mutation, in other words. And that's why these congenital immunodeficiencies are not treated. It is impossible to treat because they are caused by genetic mutations. Congenital immunodeficiency mostly occur in children. We will talk about them. And another group is acquired or secondary immunodeficiencies. They are secondary to some other diseases process affecting the normal functioning of some part of lymphoid tissues. They are secondary, they occur later. They affect normal functioning of lymphoid tissues. They are caused by using of drugs, malnutrition, and radiations used to treat cancer. We will talk about factors that cause acquired immune deficiency in this lecture too. So, congenital and acquired immune deficiency. Congenital are inherited, acquired are those immune deficiencies that are acquired, that are got but by the patient during their life. And these immune deficiencies may be treated by medications, with medications. Primary or congenital immune deficiencies are inherited. I say to you that they are caused due to mutation in genes controlling immune cells. So these genes are defected, genes in immune cells. How can we see immune deficiency in patient? Or what are clinical manifestations? These patients are susceptible to recurrent severe infections. This immune deficiency start in children in the childhood. They cannot recover without treatment, and there are more than 125 immune deficiency disorders, different immune deficiency disorders. Secondary or acquired immune deficiency occur as a consequence of other diseases or environmental factors. After infections, because of malignancy, aging, starvation, medication, and drugs. And another main cause of acquired immune deficiency is HIV virus. And we can understand it from the name of this virus, human immunodeficiency virus. It causes immune deficiency. Another question. Firstly, we will talk about primary or congenital immune deficiency, their characteristics, classification, and the first group of these deficiencies that we discuss are B cell deficiency. Firstly, primary or congenital immune deficiency can occur in 4 categories or in 4 immune mechanisms. You remember this immune mechanisms of our immune system. This is humoral mechanism that is mediated by B cells that produce antibodies. Cell-mediated mechanism that is mediated by T cells. Then complement system. You remember that complement are plasma proteins that are produced in liver and circulate in plasma in non-active form until the formation of immune complexes. When immune complexes are present, complement is activated. And the last mechanism is phagocytosis. You also remember what is it. Congenital immune deficiency includes B cell deficiency, humoral deficiency, in other words, T cell deficiency, cell-mediated, then combined B cell and T cell deficiency that includes deficiency in both systems, complement deficiency, and the last one is phagocyte deficiency. So once more, look at these mechanisms. We have humoral immune response, so it is B cell deficiency. If there is a disorder in T cell, in cell-mediated immunity, it's T cell deficiency. Then when pathology of immune system is caused by both disorders, B cells and T cell disorders, it is called combined, then complement and phagocyte deficiency. Let's talk about the first one. The first one, it is B-cell deficiency or defects in humoral mediated immunity. B-cell deficiencies are caused by the abnormal production of one or all of the immunoglobulins or antibodies. Firstly, let's talk and let's remember which immunoglobulins do you know. What are these immunoglobulins? This is IgG, IgM, IgD, IgE, IgA. So, B-cell deficiency may be caused by abnormal production, decreased production, for example, in IgM or IgG or in both. Humoral immunodeficiency may include such diseases. These are Bruton's X-linked agammaglobulinemia, then common variable immunodeficiency, and the last one is selective immunoglobulin A deficiency. So these are names of diseases that are caused by deficiency of B cells, by disorders of B cells. The first one is Bruton's X-linked agammaglobulinemia. Firstly, what is agammaglobulinemia? A in definitions means negation or absence of something. So we can understand that there is no, from this name, we can understand there are no any antibodies. What is it? Bruton X-linked agammaglobulinemia is a heritable defect in B cells that results in severe reduction in immunoglobulins, severe reduction, absence of immunoglobulins, of all immunoglobulins. It causes pyoderma, frequent skin infections, septicemia, that is multiplication of bacteria in the bloodstream, and meningitis. So these infections like pyoderma, meningitis, and septicemia are caused because of absence of immunoglobulins. So patient becomes susceptible to these infections. The another disease is selective immunoglobulin A deficiency. Selective. Just one immunoglobulin classes is absent. Immunoglobulin A. If we come back to lecture number 3, you remember that immunoglobulin A may be present in two forms. It is secretory and non-secretory immunoglobulin A. Secretory IgA is produced on the surface of mucosal membranes of nasopharynx, digestive system, urogenital tract, and secretory IgA provides local immunity. So, what happens with patients who suffer from selective immunoglobulin A deficiency? These patients have a tendency to develop recurrent means frequent, sinopulmonary infections, infections of sinusitis, of upper and lower respiratory tract, sinusitis, tonsillitis, pharyngitis, bronchitis, then gastrointestinal infections and autoimmune conditions or autoimmune diseases. Because there is no local defense, local protection in the mucosal membranes of respiratory tract and gastrointestinal tract, that's why patient is very susceptible to these infections. These sites, these tissues, these human tissues are portals for entry I remind you, these are organs and tissues where bacteria enter human organism. And the third disease, the third disease is common variable immunodeficiency, CVID. Common variable immunodeficiency is characterized by lack of B lymphocytes that results in low levels of immunoglobulin production. Just low level in Ig production. Immunoglobulins are present in plasma, but in very small amount. Such patients are suffer from frequent bacterial infections, and some patients with CVID have lymphoma. And lymphoma it is malignancy or cancer of lymphoid tissue. It's a common cause of death in patients with CVID. It develops after some years with CVID living. So we have just said about B cell deficiency. Now let's talk about T cell deficiency. T cell. You remember that T cells provide cell-mediated immunity. T cell deficiencies are caused by defects in T cells development. By the way, both CD4 cells and CD8 cells. I remind you that CD4 cells are T helpers. They don't engulf bacteria, they don't take part in phagocytosis, they just activate. T helpers produce cytokines to activate other cells. Which cells? Th1 activate CD8 cells, T killers or cytotoxic lymphocytes. Th2 activate B cells. Symptoms in T cell deficiencies are more severe than in humoral immunodeficiency. Children rarely survive beyond infancy or childhood. They live just a short period. Cell-mediated immunodeficiency disorders include such disease as Dye-George syndrome. Dye-George syndrome, or another name of this disease, is thymic hypoplasia. Thymic hypoplasia. From this name of the disease, you may understand that children don't have a thymus. They are born without a thymus. What is thymus? Let's remember about it. Let's remember what is it. Thymus, it is primary immune organ. You remember there are primary and secondary immune organs. What are primary organs? These are thymus and bone marrow. And the main function of a thymus, what is the main function of thymus? It is proliferation and antigen-independent differentiation of immune cells, of T cells. That's why such children's immune system don't produce any T cells. Any T cells. There are no any T cells in child's organism. And such children have very specific appearance. It is characterized with cleft palate, short philtrum. I will show you in photos in next slide. Short philtrum with fish mouth appearance and low set pixie-like ears. Let's look at these photos. In these photos you can see children with Dye-George syndrome. Once more, they don't have a thymus, and they have specific properties of their appearance. Pixie-like ears, they are small, like in pixies. Cleft palate, or like here, cleft palate. Plate is dissociated into two parts. and short philtrum. Philtrum, it is a space between upper lip and nose. So they have short philtrum with fish mouth appearance. Mouth is very small. We have just said about B cell deficiency and T cell deficiency, and I hope you remember that in immune system all mechanisms depend on each other. If T cells are not produced, for example, if there are no T helpers, B cells are not activated, because B cells are activated by Th2. That's why there is another group of primary immune deficiencies. It's combined B cell and T cell deficiency. Combined B cell and T cell deficiency. Combined deficiency includes disorders in both T cells and B cells, and it includes such diseases as severe combined immunodeficiency and Whisked Aldrich syndrome. Firstly, let's talk about the first one, about severe combined immunodeficiency. It is caused by genetic mutations resulting in the full absence of all immune functions. There are no any T cells, B cells, complement, phagocytes. All immune mechanisms are defected. Infants with severe combined immunodeficiency lead a short life, no more than 2 years, with chronic opportunistic infections. Such children die because of any infection, any mild infection that doesn't cause disease in normal individual, but this infection may be lethal for the child with a severe combined immunodeficiency. There are no any immune mechanisms. And such children suffer from chronic opportunistic infections. I remind you that opportunistic infections are caused by opportunistic bacteria. These are bacteria of normal microflora, but in low immunity they can cause infections. The another disease caused by combined B and T cell deficiency is Whisked Aldrich syndrome. Patients with Whisked Aldrich syndrome has decreased IgM and elevated levels of IgA. Decreased IgM and elevated IgA level. T cell dysfunction can cause Hodgkin disease. Hodgkin disease, it is malignant disease of lymphoid tissue. If there is T cell dysfunction of thymus, for example, or dysfunction in T cells, it also causes B cell dysfunction then. So Hodgkin disease is one of the most frequent diseases in patients. You remember that cell-mediated immunity, for example, CD8 cells, T killers, take a great part, play an important role in anti-tumoral immunity, because CD8 cells and natural killer cells destroy transformed human cells. Transformed human cells leads to occurrence of tumor. So if there are no, or there is deficiency of natural killer cells and T killers, it causes tumor of lymphoid tissue, Hodgkin disease, for example. Patients with Whisked Aldrich syndrome are susceptible to different infections, including septicemia, It's multiplication of bacteria in the bloodstream, meningitis, inflammation of meninges, eczema, and thrombocytopenia. What is eczema? Eczema, it is non-contagious, non-infectious inflammation of skin, mostly, especially derma, that is characterized by itching, by severe itching. So you can see in this photo, eczema of the foot. It is non-infectious. It is not caused by microorganisms. It is caused by disorders of immune cells. Because immune cells, inflammation occurs, and immune cells don't stop this inflammation. And another manifestation of Whisked Aldrich syndrome, clinical manifestation that we can see in the child, this is face petechia. Petechia, it is rashes, in other words. You can see rashes on the face of this child, and hematoma. Hematoma occurs not because of biting. Petechia and hematoma are caused by thrombocytopenia. What is thrombocytopenia? It's a loss of platelets or thrombocytes, loss or absence of these cells. What is main function of platelets in the blood? Their main function is coagulation or blood clotting. Because of loss of platelets, there is no coagulation, there is no blood clotting, so there are multiple rashes in the skin caused by bleedings, multiple bleedings, and multiple hematomas. Another type of primary immune deficiency, it is disorder of complement system, complement deficiency. Firstly, let's come back to our lecture where we talked about complement. What is complement? Complement system is an important part of the non-specific immune response. These are plasma proteins that produced in liver and present in non-active form. Complement is activated in the presence of antigen. It is activated C1, C2, C3, C4, and so on. There are about 20 components of complement from C1 up to C20. But in complement activation, just from C1 up to C9 are important. They take part in complement activation. What are main functions of complement? Why is complement activated in our organism? Complement is activated because it promotes chemotaxis. Chemotaxis is a movement of immune cells to phagocytes to the site of infection. Opsonization, it is enhancement or improvement of phagocytosis. And phagocytosis, another function. Then bacteriolysis or cytolysis of antigen, and anaphylactic reaction and inflammation. So once more, final results of complement activation, it's opsonization, enhancement of phagocytosis, lysis of antigen. Mast cell degranulation causes inflammation. Inflammation is a protective mechanism of our organism. And induction of chemotaxis. Chemotaxis is movement of phagocyte to the site of infection. So, main functions. What happens? What happens in deficiency of complement? Primary complement disorders are caused by genetic problems. They are also inherited. They are genetically mediated. These patients are more susceptible to autoimmune diseases, for example, lupus erythematosus, and increased susceptibility to pyogenic infections. Pyogenic infections are caused by pyogenic bacteria. These are Staphylococcus, Streptococcus, Neisseria meningitidis, Neisseria gonorrhea. I hope you remember which infections are caused by these pathogens. We studied it in previous semester in microbiology. I will remind you in practical class, so you should be ready. Which infections are caused by Staphylococcus, Streptococcus, Neisseria gonorrhea, and Neisseria meningitidis. Because patients with primary complement deficiency are mostly susceptible to these infections. So repeat, please. Deficiency of late complement components like C5, C6, C7, and C8 results in systemic Neisseria infections such as meningococcal sepsis, meningitis, and disseminated gonococcal infections. Disseminated means when bacteria spread in the bloodstream. Abnormalities of the control proteins of the alternative pathway. These are proteins B, D, and P. They activate alternative pathway. May result in recurrent infections. Actually, if you remember, complement includes C1, C2, C3, C4, and so on. If there is deficiency in C1, C4 components, in C2, complement may be activated by alternative pathway or lectin pathway. In this case, classical pathway is not activated. But if there is a deficiency of C3 and C5, no one pathway is activated. The another deficiency of immune system, the another primary immune deficiency, it is phagocyte deficiency. Phagocytic system composed primarily of phagocytic cells, which function is to migrate to the site of infection, adhere to the tissue, engulf invading material, and then digest it. So it is phagocytosis, engulfment, neutralization, and digestion of any antigen. A defect in the phagocytic system results in a decreased number of phagocytic cells. Amount of phagocytes decreased. Such patients are prone or susceptible to bacterial infections and often to infections caused by fungi Candida. Candida is opportunistic fungi that are always present in human organism, but they're present in small amount in vagina, in mouth. They multiply when normal microflora is destroyed. Defective phagocytes are found in chronic granulomatous disease and Chidayakygashi disease. So, which diseases are caused by phagocytosis disorders, phagocytic deficiency? It is chronic granulomatous disease and Chidayakygashi disease. What is Chidayakygashi disease? It is a rare hereditary disease. Rare. What happens there? Abnormal granules are seen in blood granulocytes, resulting in decreased chemotaxis and bactericidal activity. There are some, let's look at this diagram. This is granulocyte, and there are abnormal granules that are present inside, and phagocytes can't move to the site of infection. They don't have lytic enzymes for destruction of the pathogen, so they are not active. Such patients with Chidayakygashi disease have poor resistance to bacterial infections. This condition usually results in death of childhood before the age of 10 years old. Such children live no more than 10 years old. And there are some visible manifestations, specific manifestations of Chidayakygashi disease. Sure, we can't see, when we see the child with Chidayakygashi disease, we can't understand, we can't see his phagocytes, granulocytes. But there are some clinical manifestations. These are ocular cutaneous albinism, you can see in this photo, albinism. Then they have multiple bleedings, and multiple neurological abnormalities. So we have just said about primary immune deficiency. Now let's talk about secondary immune deficiency. They are acquired. Firstly, what are causes of secondary immune deficiencies? These are malnutrition, aging, stress. Why does stress cause secondary immune deficiency? You know that in stress some hormones are produced, some stress hormones like adrenaline, noradrenaline and cortisol. Adrenaline, firstly, activates immune cells, but then after some time of stress, when adrenaline is released, when stress is long lasting, after some time this produced adrenaline inhibit immune cells by blocking of pro-inflammatory and anti-inflammatory cytokines. So cytokines are not released, immune mechanism is not activated, so it causes secondary immune deficiency. In pregnancy is also cause of secondary immune deficiency. Why? Because antigens of the fetus, of the baby, consists of both mother's and father's antigens. Sure, immune system doesn't recognize those antigens that are like mother's, but father's antigens are recognized as foreign. That's why immune system inhibits itself, its mechanisms for successful pregnancy. Actually, a pregnancy woman, especially during the first trimester, are very susceptible to infections. They have Candida infections. Candida, this is opportunistic fungi. We will talk about it in microbiology. They often have bacterial infection, especially viral infections, because their immune mechanisms are inhibited. It is necessary for successful pregnancy. It's necessary for surviving of the baby. Because if all immune mechanisms will be active, baby cells, fetus organism will be destroyed by mother's immune system. Irradiation, X-ray, for example, kills and destroys immune cells. That's why a lot of patients who get irradiation treatment of cancer are very susceptible to infections. Severe burns also cause secondary immune deficiencies, and steroids or cortisons like prednisolone and cortisone. These drugs cause secondary immune deficiency. They inhibit immune cells. They inhibit inflammation. You remember that inflammation is a protective mechanism of immune organism. Drugs that are used to treat graft rejection cancer also cause secondary immune deficiency because these drugs are used to inhibit immune cells for successful graft rejection, for successful transplantation. In graft rejection, we use immunosuppressors. Immunosuppressors are drugs that inhibit or suppress immune system, suppress immune cells. Removal of spleen also causes immune deficiency. Maybe you know that it is very often when after car accident a patient needs to remove a spleen because if there are multiple bleedings there after car accident, spleen is destroyed. After severe biting, it must be removed. So spleen, it is secondary immune organ, main secondary immune organ. If it's removed, it causes secondary immune deficiency. Particular medications cause immune deficiency states, secondary immune deficiencies. I have started to talk about it. It's chemotherapy. Chemotherapy, these are injection of some drugs for treatment of cancer. Disease-modifying anti-rheumatic drugs. Rheumatism may be autoimmune disease that is caused by disorder of immune system when immune system recognizes our self antigens, human antigens, as non-self. So patients with rheumatoid arthritis, it is autoimmune disease. This patient must get anti-rheumatic drugs. These anti-rheumatic drugs inhibit immune cells, so inhibit immune response. And immunosuppressive drugs after organ transplants. Sure, from the name you may understand, they suppress immune system. It is necessary for successful transplantation. And glucocorticoids. Environmental toxins like mercury and other heavy metals inhibit immune system. Viral infections like HIV and other diseases like cancer and diabetes also are causes of secondary immune deficiency. In diabetes, some produced hormones inhibit immune cells. So patients with diabetes are also susceptible to bacterial infections and viral infections. Secondary immune deficiency disease acquired as a result of infections, aging, or other factors that we have just talked about. They may cause cancer. So secondary immune deficiency may occur because of cancer, and it also may cause cancer because transformed human cells are not destroyed because of blocking of immune mechanisms. Acquired immune deficiency disease may be caused by HIV virus. It is a retrovirus. This virus kills T helper cells, and this patient is susceptible to opportunistic infections. Now, I'm not going to talk about HIV a lot because we will talk about HIV in microbiology. We will talk a lot of there. So here you should remember that HIV virus kills or infect T helper cells, so T helpers are destroyed. It means that CD8 cells are not activated, T killers are not activated, so cell-mediated immune mechanism is not activated. B cells are not activated, so antibodies are not produced. So such patient with HIV have a lot of infections, a lot of different infections, and this patient may die because of any infection. Any infection may be lethal for this patient. I have said about that HIV specifically attacks the CD4 cells, the HIV antibodies produced by the immune system and unable to overcome the infection. Over time, HIV progressively weakens the immune system and the person becomes immunodeficient. He has status immunodeficient. A weak immune system can no longer effectively defend the body. How can we understand that our patient has immune deficiency? So, for example, you have a patient and you suspect that you suspect that there is immune deficiency. Why? Why have you decided? Why do you think that the patient have immune deficiency? Let's talk about it. Patients with immunodeficiency have the following manifestations. They have recurrent or often respiratory tract infections. What does it mean? It means that these are from 6 up to 8 cases of upper respiratory tract infections in a year. 2 cases of pneumonia, of diagnosed pneumonia in a year. It is considered as recurrent respiratory tract infections, upper or lower respiratory tract. These patients also have severe bacterial infections, Then, this patient have recurrence of the same type of bacteria. Recurrence means when infections are caused by the same bacteria. After some time, they are repeating. When patients have lymphadenopathy during long period, lymphadenopathy is enlargement of lymph nodes. When patients have hepatosplenomegaly, enlargement of spleen or liver. When patients have severe viral illnesses. When patients have chronic encephalitis. When the patient has adverse or abnormal pathological reactions to vaccines. When we inject vaccine and patient have this vaccine, for example, cause disease in this patient. It means he or she has immunodeficiency. Patients with immunodeficiency have intermittent fever. Intermittent fever lasts long-lasting fever. These patients also have frequent skin lesions, persistent diarrhea, and evidence of autoimmune diseases. So, let's make conclusion. Patients with immune deficiency must have some of these manifestations, 3 or 4, for example, or 2. When we observe these manifestations in patient, we can say that she or he has immunodeficiency. Which factors influence the immune status, influence the immune system? The first group of factors are climatic and geographical factors. It is temperature, humidity, solar radiation, day length. For example, we know that in winter when it is cold in Russia, when sun is almost absent, people are most susceptible to infections. We are sick, we get infected mostly in winter. Another group of factors are social factors. It includes nutrition, life conditions, job conditions. For example, people who have bad nutrition are more susceptible to infection because they don't get necessary vitamins. Life conditions, I mean, for example, where people live. They live at home, or they don't have home. Job conditions. What about this factor? For example, if we talk about me and about you, when I am teacher and your students, who is most susceptible for infections? For factors that inhibit immune system? Me because I contact with a large amount of students every day. When you will be doctors, who will be the most susceptible? You. Because every day you will contact with patients with diseases that may influence the immune system, with other factors that also inhibit immune system. Job conditions also includes work, profession, work of with some substances like heavy metals that inhibit immune system. Environmental factors also influence immune status, immune system. These are, for example, environmental pollution by radioactive substances. The inhibitors know that radioactive elements inhibit immune system and cause cancer very often. Traffic fumes, widespread use of pesticides in agriculture. They all inhibit immune system. And medical factors like drugs, surgery, stress, medical manipulations, and frequent use of radiography. Radiography, X-ray of the lungs, for example. Frequent use. Normally, to use it 1 or 2 times in a year, but no more. Sometimes we need to do it more often. So we have just said about immune deficiencies, Now this small part will be about laboratory diagnosis of immune deficiency. It is lecture number 6. Here we will talk about laboratory diagnosis of immune deficiency in children and adults. How to diagnose these states in children and adult patients. Firstly, what is immune status? Immune status is the human body clinical state, quantitative and functional state of the humoral and cellular immunity factors. Once more, it is human body clinical states. Quantitative means amount of immune cells, for example, and functional, their functional activity, functional state of humoral and cellular immunity. The indications for the investigation of the immune status includes propensity to chronic purulent septic infection, when our patient have long-lasting chronic purulent septic infections, cancer, and other diseases when immune deficiency is suspected. We have said about it, clinical manifestations. I have explained to you clinical manifestations. So when we can see some of these clinical manifestations in patient, we should diagnose immune deficiency. We should investigate immune status. Healthy individuals who work in extreme or harmful conditions must be diagnosed for the presence or absence of immune deficiency. We should investigate immune status of these patients. Which methods are used for laboratory diagnosis of immune status? These are ambulatory tests and immunological laboratory tests, combination of both. Ambulatory tests that are made in clinical checkup. Ambulatory test includes visible clinical manifestations, and then immunological laboratory tests that prove immune deficiency in patient. Which methods are used for it? Once more. Firstly, it is data of clinical checkup. Ambulatory examination, when you observe your patient and when you can see, for example, lymphadenopathies, hepatic splenomegaly, then frequent skin lesions. These are data of clinical checkup. Then we should evaluate indexes characterizing the state of the innate immunity. It is complement system activity, amount and activity of phagocytes, activity of protective serum proteins such as C-reactive protein and beta-lysine. Innate immunity or non-specific immunity. We talked about innate or non-specific immunity in lecture 2. Once more, what are these factors? Phagocytosis, complement, cytokines. So we should we should study these parameters. Then, indexes characterizing the state of humoral immunity. Humoral immunity is mediated by B cells, so we can detect activity and amount of B cells and amount of immunoglobulins produced by these B cells. Then, indexes characterizing the state of cell-mediated immunity. You know that cell-mediated immunity includes T cells. So we can detect amount and activity of T cells, for example, T helpers, and also natural killer cells. Natural killer cells are not T cells, but they also included in cell-mediated immunity. And results of some additional tests that we will discuss. Levels of evaluation of immune status. So there are two stages that are used, tests of 2 stages that are used for evaluation of immune status. First stage tests are tentative. Tentative means they are made when we suspect immunodeficiency in patient. If this test shows deficiency in one or several mechanisms, we should make second stage tests. But if first stage are negative, they shows normal activity of immune mechanisms, we don't do second stage tests. So what about first stage tests? First stage tests include some tests. These are clinical analysis of peripheral blood or blood test. In blood test, we can see amount of red blood cells, for example. Then, amount of lymphocytes in the blood. It is the first test that is made. And we can see amount of different cells, different immune cells, blood cells and immune cells. Then we should determine number of T and B cells. Number of T and B cells in the blood of the patient. Then we should identify major classes of immunoglobulins, IgM, IgG or IgA in serum, and identify phagocytic activity of the leukocytes. So this one, a determination number of T and B cells. It is when we determine number. If there is any deficiency, if there is any disorder, if some parameters are decreased or increased, we should make second stage tests. What are second stage tests? They are analytical. They allow to see which immune mechanism is destroyed, which immune mechanism is not active. What is level of immune deficiency? Second stage test includes identification of the subpopulations of the regulatory T cells. So in first stage tests, we detect amount of T cells. In second, we detect how much T cells, T helpers, T killers, then T suppressors are present in the blood. The second test is identification of the spontaneous migration of the leukocytes and leukocytes migration inhibition test with the use of fetal hemagglutinin test. Don't be afraid, I will explain. So, spontaneous migration is used. Spontaneous migration test is used to detect activity activity of immune cells. Because sometimes immune cells may be present in the blood, but they are not active. Then skin allergic test with tuberculin and other allergens to which there are sensitization in most populations. Then study of the proliferative activity of T cells in response to mitogens, antigens in blood transformation. Proliferative activity means ability of T cells to proliferate into T helpers, T killers, because T cells may be present in normal amount in the bloodstream, but they are not able to proliferate, so they are not active. And the last one is determination of the dynamics. Dynamics means production, how it changes. Dynamics of major cytokines that regulate cellular and humoral immune response and modulate inflammation. Firstly, I want to remind you what are cytokines. What are cytokines? Cytokines are non-specific proteins of human organisms that are produced by immune cells and activate other immune cells. Cytokines are like intercellular messengers between all immune cells. So we can detect which cytokines are produced, which are not produced. For example, interferon gamma, tumor necrosis factor alpha, interleukin 2 that are pro-inflammatory cytokines, they cause inflammation, and interleukin 4, 5, 6, and 10 that are anti-inflammatory. Now let's talk about first stage tests. First stage tests that are tentative. The first I have said about them. How are they done? The first test that is used here, it is test for determination of the T and B cells amount in the blood. So we should determine amount of T and B cells. How is it done? We use rosette forming test. Rosette forming test is used to determine amount of T and B cells. How is it done? We know that CD3 receptor of human T cells and B cells can bind with sheep blood, red blood cells. CD3 is present on the surface of all lymphocytes, both T and B cells. And this CD3 cluster of differentiation can bind with sheep red blood cells. Rosette forming cell is considered the lymphocytes if it joins 3 or more sheep erythrocytes or red blood cells. How we can count how many lymphocytes are present? We should take a slide, put the blood, place the blood on the slide, stain this blood by Romanovsky Himse, staining Romanovsky Himse. Romanovsky Himse is used in microbiology and in immunology, in biology. Romanovsky Himse staining is used for staining of blood. And we can see that lymphocytes are purple, they're present in the center, and red blood cells are pink, they are present around the lymphocytes. So this cell is a T cell or B cell if there are more than 3 red blood cells. Let's count how many red blood cells are present around this lymphocyte in this rosette. Rosette, it is a combination of lymphocyte and red blood cells. Let's count how many are present. 1, 2, 3, 4. More. It is written here. If lymphocyte join 3 or more red blood cells. So one lymphocyte, another one, another lymphocyte. Let's count how many red blood cells? 1, 2, 3, 4, 5, 3, more than 3, so this is also lymphocyte. And we should count in smear how many such cells that form rosettes are present. And if amount of such lymphocytes is from 55% up to 80%, it's in percent. In absolute amount, it's from 800 up to 2000 lymphocytes. It is okay. There is no immunodeficiency. Normal patient have this amount of lymphocytes. So we have discussed how to detect amount of T and B cells in the blood. The another first stage test is used for identification of major classes of immunoglobulins, M, G, A. How is it done? It is done in radial immunodiffusion. We will discuss mechanisms of serological tests in immunology later. Next lecture. So it is radial immunodiffusion. In this diagram you can see. Immune serum of the patient, immune serum of the patient with immunoglobulin is added in a nutrient medium. Then we should cut some holes or pores, holes in this medium, and we should add antigens in different concentrations here. And these white zones mean interaction of antigens and antibodies of human serum. If this white zone is this ring is bigger, means amount of antigen is bigger here. That binds to antibody. So another method that is used for detection of immunoglobulins is ELISA, or enzyme-linked immunosorbent assay, or analysis. I will explain it. Its mechanism will be explained in next lecture. We can see a result in this photo. It is like we can call it tablet, and we can see some tubes here. Some of them are colored in yellow. It is positive test for the presence of detected immunoglobulin. In these tubes, immunoglobulins are absent. The third test that is used in first stage tests, it is identification of phagocytic activity of leukocytes. You remember phagocytic. We have talked about phagocytic number and opsonic phagocytic index. Phagocytic number is the average number of bacteria present intracellularly in phagocyte or ingested per one phagocyte. We can count how many phagocytes are present. But we also should detect opsonic phagocytic index. Opsonic phagocytic index, it is a ratio of bacteria that are destroyed by phagocyte in patient's blood to the amount of bacteria destroyed in normal blood. So it was there was about first stage test. How are they done? Now about second stage test. Second stage test. The first one, it is used for identification of subpopulation of T cells. Subpopulation of T cells, T helpers or T killers or T suppressors. It is made by immunofluorescence test. I will explain this mechanism next lecture, so you should just memorize immunofluorescence test. The second test that is used here, it's used for detection of proliferative activity of T cells. Proliferative, once more, proliferation, when T cells proliferate into subpopulations, T killers or T suppressors. Its ability for their differentiation. This test, this ability is studied in blastic transformation test. Blastic transformation test. Lymphocyte blast transformation. It is the transformation of lymphocytes to lymphoblasts that are capable to proliferate and differentiate. So lymphoblasts are progenitors, are pre-cells for lymphocytes. We can collect blood from the patient with lymphocytes and do blastic transformation test with these lymphocytes. If they are able to be transformed in lymphoblasts, it's okay. How to do it? Firstly, in this blastic transformation test, we use specific and non-specific stimulants. Stimulants, these are substances, mitogens, are compounds that stimulate mitosis. Mitosis means multiplication. These mitogens may cause blast transformation. Blast transformation. A non-specific phytogenic mitogen is a phytohemagglutinin. Phytohemagglutinin also may be used to stimulate blastic transformation of lymphocytes to lymphoblasts. For example, it is lectin that is found in plants, especially in certain legumes. So we add mitogen or phytohemagglutinin in blood. In patient's blood, and then we should observe how many lymphocytes are transformed to lymphoblast, and we should count how many lymphocytes are transformed into lymphoblasts. Normally about 70–80% of peripheral human blood lymphocytes are transformed into lymphoblasts under the influence of phytohemagglutinin or other mitogens. So this test, this plastic transformation test, reflects functional activity of T cells, their ability to differentiate. The another one, it is a test that is used for determination of the dynamics of major cytokines that regulate cellular and humoral immune response. Determination of major cytokines. Cytokines are proteins that are produced immune cells and regulate, activate or inhibit other immune cells. This determination is made in ELISA test. ELISA test, I will explain it next time. Now you may just see in this diagram, for example, in this plate, there are some samples of cytokines, 4 lines, and some of them are colored. So it means the presence of various cytokines there. So there were main tests for determination of immunodeficiency states in patient, and after we determine immunological parameters in our patient, we may collect these parameters: amount of T cells, activity of T and B cells, amount of immunoglobulins, blastic transformation of T cells. We may collect these parameters in immunogram. What is immunogram? Immunogram is advanced clinical analysis of blood with immunological parameters, number of T and B cells, and so on, that we have just discussed, which indicate the status of immunity, level of immunity. How to evaluate immunogram? We should compare each indicator at intervals of variation over the norm. Then we should use registration of possible individual characteristics. Age, disease, for example, in age we know that amount of immune cells decreased. In older patients, we should understand it. Physiological and pathological factors, nutrition, physical activity, time of day, effect of stressors, all factors that influence immune status. The another rule is a comprehensive analysis. It means that we don't talk about one single indicator. We should make a conclusion when we can see decreasing or increasing of some indicators. The another rule, it is assessment of significant changes in indicators. Assessment of significant changes means at least 20% of the norm. For example, if amount of T cells is decreased just little bit, it is not the cause, it is not the parameter criteria of immunodeficiency. It doesn't mean that our patient has immunodeficiency. No. We should detect it by using of significant changes. Then we should use a rule of dynamic analysis of parameters. Dynamic analysis, not just single time, not one time, but during the same time. For example, today, then after 1 month, then once more and once more. And we should compare these immunograms that are made several times. You can conduct full analysis immunogram only in conjunction with clinical evaluation in this patient. I have said about clinical checkup. The first method for evaluation of immune status, it is clinical checkup. And we should compare, we should talk about in combination of clinical manifestations and immunological tests that we have discussed. In this slide, you can see example of immunogram. It is not full immunogram. Actually, a full immunogram is bigger. We will talk about it in practical class. For example, index T cells, amount in percent and absolute amount of B cells, a ratio of CD4 to CD8, phagocytic number, then circulatory immune complexes. You remember that they are detected in hypersensitivity type 3, then amount of IgM, IgG, IgA. And we should compare these parameters with normal parameters. We will do such case, we will do these tasks at class. So, that's all. Thanks for your attention. Take care of you. Prepare this lecture